Now we will cover calcium channel blockers and beta blockers. The calcium channel blockers have two main groups, the dihydropyridine and the non-dihydropyridine. Dihydropyridine is the new group, while the non-dihydro is the old group and is very commonly used right now for hypertension like amlodipine, rilcandipine, and philodipine. The main effect of this medication on the blood vessels, so they usually decrease the blood pressure, so used for hypertension and angina, and they are safe to be used in heart failure because they do not affect the heart rate or the contraction of the heart. The side effect is mainly ankle edema, which can lead to discontinuation and shifting to another drug. Headache and flushing also can occur, and this is because of the mechanism of action, which can cause vasodilation in the head and the face, causing headache and flushing. The non-dihydropyridine group is the old group of medication like diltiazem and verapamil. The main effect not on the blood vessel, on the heart, so they usually decrease the heart rate and the contraction, and usually used for the heart rate control and better to avoid in heart failure. The main side effect of the old group is that can cause bradycardia. Constipation also can occur with verapamil. There is an important safety point is not to combine these drugs with beta blocker because both medication will further decrease heart rate, can cause heart block or asystole and patient death. Beta blockers. Beta blockers have a lot of indication, sometimes used for hypertension, for resistant hypertension as add-on medication, and they are not anyway first-line drugs right now. They can be used for other indication like headache and portal hypertension. So the main group of beta blocker depend on its selectivity on the beta receptor because beta receptor available in the heart as beta 1 and in the lung as beta 2. Blocking the beta 1 receptor cause decrease in heart rate contraction, and blocking a beta 2 receptor can cause bronchoconstriction and can deteriorate asthma or respiratory disease. So the beta 1 selective called cardioselective like bisoprolol, metoprolol, or antinolol, and this is usually used medication because they are safe in asthma and COPD. For the non-selective agents, they block both beta 1 and beta 2, so they are not safe in asthma, like propranolol and nadolol, and propranolol usually used for preventing migraine, not as a blood pressure medication. There is another group that work on alpha and beta blocker. So alpha blocking cause extra vasodilation, which is causing enhanced blood pressure control. So they are used in hypertension mainly like carvedilol and labetalol. They use in hypertension and heart failure. The ultra short acting or IV drugs, they are having a very short half-life up to 9 minutes, so they can cause rapid control of blood pressure in critical care setting. The example of this drug is esmolol. The main side effect of beta blocker include bradycardia because they decrease the contraction, hypotension, fatigue because they block beta receptor in the muscles, bronchospasm due to blocking the beta 2 receptor in the lung, and masking hypoglycemia symptoms. So patient having hypoglycemia, they have an alarm symptom of tachycardia, which make him aware of this hypoglycemia. While on beta blocker will depress the tachycardia, so the patient may develop hypoglycemia without any alarm symptoms. An important safety point here, there is an absolute indication, contraindication for beta blocker to be used in case of severe bradycardia, high degree AV block, or acute decompensated heart failure, because this condition, the heart rate is very low and the contraction is very low, so it is very dangerous to use beta blocker in these conditions. In order to stop beta blocker, we do not stop it abruptly, because it will cause rebound, hypertension, or myocardial infarction. For use of beta blocker in heart failure with reduced ejection fraction, which called HFrEF, if the patient is stable, so they having a mortality benefit, so this can be used, especially bisoprolol, metoprolol, and carvedilol. In case of acute decompensated heart failure, so we do not initiate a beta blocker because this condition is unstable and highly deteriorated.